Welcome to the Renal Research Institute's Frontiers in Kidney Medicine and Biology, where we share knowledge and advances in kidney research with the world. It's my great pleasure to welcome today Dr. Pecoit-Filho. Dr. Pecoit-Filho is a senior research scientist at the Arbor Collaborative for Health in Michigan and a professor of medicine at the Pontifical Catholic University of Paraná in Curitiba, Brazil. He is the current chair of the Education Committee of the International Society of Nephrology. As a clinician, he has broad activities in internal medicine and nephrology based at the university-affiliated hospital, where he was chief of the Department of Internal Medicine between 2010 and 16, the director of residency program in nephrology from 2013 to 2016. Dr. Pecoit-Filho is principal investigator for the study CKTOPS, a multinational study on practice patterns and outcomes in chronic kidney disease, and he acts as the scientific leader for clinical trials in the Americas with the George Clinical. Dr. Pecoit-Filho received his MD and trained in internal medicine and nephrology in Curitiba, Brazil, before completing a nephrology research fellowship at the University of Missouri, Columbia, and a PhD from the University of Sao Paulo. He was a visiting scholar for extended periods at the Karolinska Institute in Stockholm, Sweden, and the George Institute in Australia. And he has participated as principal investigator, regional leader, and in steering committees in multinational clinical trials. Dr. Pecoit-Filho served as a member of the Executive Committee of the International Society of Nephrology, the Song Initiative, and KDIGO. Roberto, welcome, and I'm wondering, could you just say a few general words about renal anemia? What is it? What's the traditional thinking, where it comes from, how prevalent is it, and what is the consequence of renal anemia?
Yeah, hi Peter, and well, first of all, thanks so much for inviting me to chat with you today. My pleasure. And also a pleasure to talk about anemia, which is one of the main topics of my research in the last several years. But I guess my interest in the topic comes from observing and treating patients. And I would start by saying that this is one of the problems that affect patients' lives, the way they feel, and their perspective of living well and long. I think there are two things that anemia does to patients. One is when anemia develops, they feel worse. And that has a profound impact in the way they feel in terms of physical and mental activity. They feel fatigued, they feel tired, they feel dizzy, and they get much better when we treat them. The other problem is that in the long term, it seems like anemia, which we monitor by measuring hemoglobin levels. When anemia develops, it represents a risk for patients' longevity in the long term, and I think that's another thing that patients want, is to live longer and to live well. So I think that's the main motivation for us as clinicians and researchers to be so interested about this topic. And anemia obviously is not a condition that affects only patients with kidney disease, but is actually very, very common in patients with kidney disease. First of all, anemia worsens as kidney disease progresses. And kidney disease is a disease that has a spectrum from a very mild kidney disease to a very severe one. And at the end of the spectrum, patients require kidney replacement therapies like dialysis and transplantation. And if we focus on that end of the spectrum, I think the anemia is actually very common. And most patients require active treatment to control anemia. While, when kidney disease is starting to develop, anemia is not that common. And I think the motivation for us to, keep studying anemia is the fact that with the current available treatments, we are not really solving the problem for all patients. And I guess this will be the focus of our discussion today.
Yeah, that's right. But before we go into this, anemia, so the lack of red blood cells and low hemoglobin levels, occurs also in non-kidney patients or subjects, like particularly in, I think it's more prevalent in younger women, for example. What is the difference between the anemia we observe, say, with iron deficiency, as opposed to the anemia we observe in kidney patients? I believe there are some fundamental differences. Could you say a few words about that?
Yeah, sure. It is quite different. The mechanisms behind anemia of kidney disease, they have some peculiar aspects. I think the most important one is the fact that there is a hormone that stimulates the differentiation from stem cells in the bone marrow into circulating red blood cells, which is called erythropoietin. And this hormone is actually produced, actually stimulated by low oxygen levels in the circulation, or low hemoglobin levels. This hormone is produced by the kidneys. It actually has an important function to do that differentiation into the precursors of red blood cells into the final mature cells. In patients with decreased kidney function, they lack, or the production of this hormone is a significant decrease. That's perhaps one of the reasons why anemia worsens with the increased severity of kidney disease, because the worse the kidney function is, the lower the production of this hormone also is. The other aspect is related to iron metabolism. And patients with kidney disease, usually they show signs of systemic inflammation. And this inflammation, which is due to several things in patients with kidney disease, for instance, the comorbidities around it. A lot of kidney disease patients are diabetic patients. They have comorbidities like hypertension, like heart failure and other problems. And together with the decreasing the clearance of some molecules that might alter the physiology of the body, that we call the uremic toxins, there is a chronic stimuli to the production of an inflammatory response. And one of the consequences of the inflammatory response is a disruption in the way that we can use iron from our stores. So usually patients with kidney disease, they are iron deficient. Sometimes they have the iron somewhere stored in the body, but they have a problem using it. And I think those two aspects, at least from a more traditional way of seeing anemia in kidney disease, those two aspects have been identified as the main problems that determine a reduction in hemoglobin levels or anemia, but also have been important as motivators and actually targets for interventions or treatments that we use in patients with kidney disease to treat their anemia.
So I think you really pointed out this important role of erythropoietin that's produced in the kidney and that's stimulated by sensing a low oxygen concentration or oxygen saturation in the kidney. And can you just talk a bit about the use of erythropoietin in the treatment of anemia? I mean, I recall very, very well, and now I think it's some 40 years ago, when erythropoietin was started to be used for the treatment of anemia in kidney patients. And what was seen were it was like magic. You would give erythropoietin and hemoglobin levels would just shoot up. And so this was certainly an extremely exciting time, and patients just felt better. But then there were data that actually treating patients to the extent that their hemoglobin levels would normalize may not be such a good idea. So where does this trade-off come in? On one hand, you want to normalize the level, which seemed to be reasonable. On the other hand, it turned out to be not beneficial for the patient. So what's this fine balance in that respect?
Yeah, it is a fascinating story, isn't it? And I also have been a nephrologist long enough to have seen the transition. And I was a resident actually when I saw the first patient being treated with a synthetic erythropoietin late in the 90s. And I think I had the same feeling that you had, being so impressed about that, because in the past there were no options, right? So we were just sort of rescuing patients from very severe anemia with transfusions, and then generate this cycle of patients all feeling better after transfusions, and then feeling worse over time when that the effect of transfusions faded away, and actually seeing all the consequences of transfusion in the lives of patients. I mean, transfusions lead to risk of infections. You probably remember the time that we had, so many problems with viral infections in dialysis patients, the hepatitis surges, and that was also a sign that the previous treatment was not really adequate. So it was really really a life-changing therapy for patients, and we could really feel that. And I think what came after that is the feeling that with this treatment you can actually normalize hemoglobin levels, and patients will feel better and better as hemoglobin goes up to the levels of people or healthy people. And that, I think that's what brought complexity to the field. The fact that when the erythropoietin, the synthetic erythropoietin, was used to try to normalize hemoglobin levels, there was a signal of cardiovascular risk in those patients. In the trials that really tried to normalize hemoglobin, giving erythropoietin, synthetic one. We need to remember that sometimes, or for some patients, the dose of erythropoietin that was needed to normalize hemoglobin or to bring hemoglobin to a level that is in the target or even above the target in some of the interventions is not very physiologic. It's several-fold higher than circulating erythropoietin that healthy people would have. So there was first of all, there was the observation of an increased risk when erythropoietin was given to patients, especially at higher doses. And at the same time, there was a reaction to redefine the targets to a range of hemoglobin a little bit below the physiological hemoglobin range of healthy people that defined the treatment that sustained until today.
Actually, now thinking back, there was this sort of discussion, medical community, but also industry, what the target levels should be. And I think that companies that produced EPO or in some form or others, they may have had an interest to go for actually higher hemoglobin levels on one hand, but then the data that came out that lower levels might be actually beneficial. I don't know if you had the same experience than I, to see this back and forth between medical community and industry, what the target level should be. And it took quite a while, I would say 20 plus years, right, to settle on where we are now. So how do you see this conversation between medical community, patient outcomes, and I guess also industry interests in prescribing more erythropoietin?
Yeah. Well, Peter, I think the idea to normalize hemoglobin was a good one, and perhaps a match between the industry strategy, but also a medical question that was relevant. So when the trials that showed this increased risk in higher hemoglobin levels came out, until they came out, I think there was a match between what patients would like to see, feel even better, what docs would like to have in terms of new information to guide their practice, and also allow for let's say a broader treatment range, maybe reaching more patients and perhaps even higher doses. The problem is that the trials, they provide this answer that was quite clear, that there was this risk in the more aggressive treated patients. And I think maybe something else that is even more difficult to understand until today is that there was not a very clear benefit from increasing those levels, even from a patient-reported outcome level. I mean, we really felt that when normalizing hemoglobin, we will create or we will impact patients' symptoms and the way that they feel. And that was not very clear from those studies. And I think that's one of the reasons why today there is no question about limiting the upper level of hemoglobin as a target to something that is below what a healthy person would require to feel better. And I think this has been the status quo for many years now, because we're still trying to do that the same way that we did it 20 years ago, giving iron replacement to patients and providing exogenous erythropoietin.
I mean, the thought to replace erythropoietin is very much in line with supplementing other missing hormones, like in type 1 diabetes or in certain specific disorders of growth, and many other examples exist in medicine, of course. But you also mentioned, and this is now interesting, that erythropoietin that's produced by the kidneys is produced in response to low oxygen levels. And I think this has opened now new avenues of treatment. Can you say a few words about how is this low oxygen level actually sensed in a way, without going too much into the details, of course, because it's a really complicated pathway, and how this can be used actually for new treatment approaches?
Right. Yeah. So and this is super relevant scientifically, and recognized even by the Nobel Prize, right? So this is the discovery of this pathway that involves a hypoxia-inducible factor that is involved in sensing oxygen and regulating endogenous erythropoietin production, has led to the Nobel Prize of Medicine in 2019, which was given to 3 investigators that discovered this and investigated this area, including the first nephrologist who ever won the Nobel Prize in Physiology and Medicine. It is a fantastic way of understanding how this is a self-regulated and tightly regulated process. The idea that stabilizing this hypoxia-inducible factor has an influence in leading to the endogenous erythropoietin production. And because stabilizers of the HIF, as we call the hypoxia-inducible factor, have been developed in terms of pharmacology. This has led to the a series of studies from preclinical to clinical studies all the way into phase 3 trials that really look at safety and efficacy of the drug in the population where the drug will be used with the indication of treating anemia. It's a fantastic story that it shows the value of the translational research from the bench to the bedside in a very short period, if you think. I mean, it's not more than 15 years perhaps since the discovery of the pathway to the application in a potential new treatment.
Yeah, and we'll see, I think, in large populations once this class of drugs becomes available, what the impact will be, and maybe do you think actually that target levels may need to be redefined for this class of drugs?
That's $1 million question, right? Are we ever going to be able to do again what we did in the early 2000s? And try again to bring hemoglobin levels to something that is closer to what healthy people would have. In theory, if the initial studies that would have to target the same hemoglobin range that is preconized by the current evidence-based recommendations, if those trials show safety, there is always the chance of trying to design trials to challenge that again. But this is always a very complicated population to study, because patients with kidney disease, particularly with more severe kidney disease, and that's when anemia becomes a prevalent problem. They are very fragile, and I think we need to be very careful when challenging, the current therapeutic approaches, and do that in a very planned and trying to keep patient safety in front of all other aspects of the clinical trial objectives.
Yeah, no, I certainly agree. I just wanted to bring this to the table because it certainly goes through my mind. What will happen with target ranges with this absolutely new approach? Now, what we didn't touch on is actually something very interesting, that the lifespan of red blood cells in patients with kidney disease is shorter. So in you and I, the red blood cell lifespan would be something like, say, 110, 120, 130 days, something in the ballpark. In patients with kidney disease, on average, it's reduced, say, 60 days, 70 days, 80 days, something in that ballpark. I am wondering, first, what do you think are the reasons for this shortened lifespan? And second, do you see in principle a totally new therapeutic approach that could aim to increase that lifespan of red blood cells?
Well, first of all, Peter, I think this is from a mechanistic point of view. I think this is the new kid on the block, right? Because I mean, as you said, we during our conversations, but also during the more traditional approach to understanding the mechanisms behind anemia and chronic kidney disease, what we discuss here, iron metabolism and erythropoietin production has been in the research agenda for many years and led to discoveries that transformed the treatment. But really, the reduction in red blood cell span has not been that much investigated. I think just hearing you say what is the impact of kidney disease on the lifespan of a red blood cell, it really shows that this is significant and probably clinically relevant. And so I do agree that this is a new area that has not been investigated enough, both from a mechanistic point of view, but also in the perspective of becoming a potential therapeutic discovery. So I do believe that, first of all, that this is clinically relevant, and this might explain, at least in part, why patients a subgroup of patients, maybe about 10% of patients that we treat with anemia the way we treat today, even with all efforts, we cannot really achieve the targets, what we call erythropoietin agent hyporesponsive patients. And perhaps those patients, at least part of those patients, might not achieve the targets because for some reason their red blood cell span is more severely reduced. Another challenge is how to monitor that. We don't monitor that on a regular basis, and that always causes a problem. It's very easy to monitor anemia with hemoglobin levels or even iron deficiency with TSAT and ferritin levels, but there is no biomarker of red blood cell span. And that's when perhaps we will need to call people that might model physiology and clinical practice with mathematical models to help us to understand that. And I know that you've been collaborating with a group of mathematicians in this matter, and I think some of the information that came out of that really shows that that from a modeling perspective, that seemed to be a relevant problem related to reduction in red blood cells span.
And I agree. I mean, it would be terrific if you would have markers of red blood cell lifespan or of red blood cell death, which is called erythroptosis. If you would have easy markers to measure those, and this certainly could open a new field, and even to think about how to treat patients so their red blood cell lifespan gets expanded. And as you said, mathematical modeling plays a crucial role in elucidating this. Now, you are a very, very international clinician and researcher. And I'm wondering, in low and low middle income countries, in your experience, from what you know, do they have access to drugs that are used to treat anemia, or is there a real shortfall in those medications?
Well, I think there's definitely a variation in access to care in nephrology in general for CKD patients, but in particular to anemia. I think the advent of developing biosimilar drugs for erythropoietin, for the synthetic erythropoietin, was very helpful in increasing access. So if you go to Africa or India or South America, you would see a lot of those drugs at a much lower cost. And that, I think that has had a significant impact in improving access to erythropoietin. Iron is another complicated issue because iron delivery to patients involves not only the availability of the drug itself, the supplement, but also the logistic around it. So I think particularly in patients that are not on dialysis, for those, for instance, dialyzing at home with peritoneal dialysis, or for those not yet on dialysis, the logistics around it also create a difficulty. And I think it's possible to see the disparities in access to iron treatment, particularly in patients in that population that doesn't really go to the dialysis center to get this treatment. So I think the distribution of care, home or in-center, and the availability of low-cost therapies are really defining the disparities nowadays, and you can really feel it. And then when you look at the results of this, meaning the percentage of patients who live with a low hemoglobin, who live with anemia, with all the consequences in quality of life and long-term outcomes, I think we are really seeing important disparities in relationship to the treatment on anemia and the achieved in targets in populations. I suspect that this is actually a bigger problem in patients not on dialysis.
So what about oral iron therapy, which is cheap and logistically may not be that challenging? You don't think that's an option because of the inflammation in those patients?
I mean, if we talk about the patients with more severe disease who are on dialysis, the degree of inflammation and demand of iron that these patients have probably will require in most patients IV therapy, intravenous infusions. For the non-dialysis population and for patients on home dialysis like peritoneal dialysis, I think there is a proportion of patients who could take oral iron. The problem is that the formulations, sometimes they are not very tolerated by patients. So compliance is another issue. And just in terms of perspective, Peter, this is another potential advantage of the new therapies with the stabilizers of the HIF that we discussed just a while ago. Because different from ESA and iron, who really target a very specific part of the pathophysiology of anemia and chronic kidney disease, the HIF stabilizers, they interfere in both. So they generate this increase in endogenous erythropoietin up to something that is much more physiological than what we see in the exogenous administration that we used to treat patients for many years. But at the same time, the stabilization of HIF leads to a better use of the iron stores. They're really blocked in patients who are inflamed. And because of the actions of this new treatment target, let's say, a lot of this iron is more easily used. And this has been one of the characteristics of the findings in the trials that we've seen published already with these new agents, that even patients with signs of inflammation and with lower iron stores, they seem to be responding very well with the stabilization of HIF and increasing hemoglobin levels. So perhaps, this new treatment paradigm might actually lead to something that deals better with the offer of iron too.
Very interesting perspective. Roberto, we are coming to the end of our conversation. I've certainly learned a lot through this, through talking with you, not only now, but over the many years we're working together on a wide range of topics. For our audience, just to wrap this up, what are key messages you would like to convey, to communicate to our audience before we close this?
First of all, Peter, likewise, it's been a pleasure, collaborating in this area and other areas with you and the Renal Research Institute group. And I'm very happy to see, that some of the things that we share with the audience today have been the consequence of this collaboration with many people involved, both in the basic research area, like Andrea Moreno and her group, but also, as we mentioned, the group of mathematicians at the Renal Research Institute. And I think that really shows the value of collaboration in clinical science and in science in general, when you bring together people from different backgrounds. And I think my final message is really a positive message that really supports the idea that the best science perhaps is done when people with multiple backgrounds and different ways of thinking join open discussions with a perspective that clearly has an application at the end. And in this case, I think what we've done in the past had always had a very strong motivation in improvement the lives of patients with chronic kidney disease. And I would just like to leave it in this note that this is really what research is all about, right? It's really trying to evolve in the field with a focus on how this can potentially benefit our patients.
I agree full-heartedly what you say, especially when it comes also to collaboration of people with different backgrounds. This is really where new insights happen. Roberto, thank you so much for this really interesting conversation, and I'm looking forward to many more conversations to come. Be well.
Yeah, you too. Bye-bye.
That concludes this episode of Frontiers in Kidney Medicine and Biology. Thanks for listening. We hope you'll subscribe and join us again for another episode.